Good day, esteemed colleagues and future dermatology experts. Today, we embark on an exploration of Streptococcal Pyoderma, a prevalent and impactful bacterial skin infection that every dermatologist and resident should be well versed in. Our journey will traverse the landscapes of its epidemiology, delve into the intricacies of its etiology and pathogenesis, and navigate through the clinical manifestations, diagnostic strategies, and treatment protocols that ensure effective management of this condition. Imagine a bustling community where children play, skin barriers are frequently compromised, and hygiene practices may sometimes falter. In such environments, Streptococcal pyoderma thrives, primarily affecting the superficial layers of the skin. It's a condition that doesn't discriminate, though it predominantly casts its shadow over children aged between 2 and 10 years, a demographic particularly susceptible due to their active lifestyles and developing immune systems. Globally, Streptococcal pyoderma finds its footing in regions with tropical climates, or areas where hygiene may be challenging to maintain. Yet, it's not just environmental factors at play. Personal health and societal conditions intertwine to elevate the risk. Compromised skin barriers from eczema, wounds, or burns provide the perfect entry point for these bacteria. Add to this the factors of crowded living conditions, recent viral infections like varicella, and we have a recipe for recurrent and persistent infections. At the heart of Streptococcal pyoderma lies the formidable group A Streptococcus, gas, scientifically known as Streptococcus pyogenes. This organism is the primary architect of the condition, though occasionally, groups C and G streptococci make their presence felt. Understanding the biology of these bacteria is crucial, as it informs both our diagnostic and therapeutic approaches. When these streptococci find their way into the skin, perhaps through a minor cut or an eczema flare-up, they don't just linger passively. Equipped with virulence factors like the M protein, which thwarts phagocytosis, and exotoxins that act as superantigens, these bacteria orchestrate a robust invasion. Hyaluronidase further facilitates their journey deeper into the tissue, evading the host's immune defenses and setting the stage for inflammation and pus formation. Picture a patient walking into your clinic with a red, swollen area on their face or limbs. The redness, or erythema, is more than just a superficial sign. It's a window into the underlying inflammatory process. Accompanying this may be swelling, edema that speaks to the body's attempt to isolate and combat the infection. Pain or tenderness is often present, especially in cases of cellulitis, signaling deeper tissue involvement. Streptococcal pyoderma doesn't present itself in a one-size-fits-all manner. It morphs into various forms. Impetigo, perhaps the most recognizable form, Impetigo can be further categorized into non-bullous and bullous types. Non-bullous impetigo is characterized by honey-colored crusts, often adorning the face, especially around the nose and mouth. In contrast, bullous impetigo presents with flaccid bulli that rupture, leaving behind large erosions. Ecthyma, a more severe variant of impetigo, ecthyma delves deeper into the skin layers, presenting as ulcerative lesions cloaked in crusts, typically on the lower limbs. Cellulitis, when the infection spreads beyond the superficial skin layers, cellulitis emerges as a diffuse, erythematous, and swollen area, sometimes accompanied by systemic symptoms like fever and malaise. Folliculitis. This manifestation involves the inflammation of hair follicles, leading to pustule formation. Differentiating Streptococcal pyoderma from other skin infections is pivotal. While staphylococcal infections may present with more localized pustules and abscesses, conditions like dermatitis or fungal infections such as Tinea species create their own distinct clinical pictures. A keen eye and thorough understanding of these nuances are essential in making an accurate diagnosis. Diagnosis often begins with a detailed history and a meticulous physical examination. The rapid onset of symptoms, the presence of purulent lesions, and the distribution pattern provide critical clues. However, to cement our clinical suspicions, laboratory diagnostics play a supporting role. Microscopy and culture are the cornerstones of laboratory diagnosis. By obtaining a swab from the base of the lesion, prior to the application of any topical agents, we can perform a gram stain, revealing gram-positive cocci in chains, a hallmark of streptococcal infection. Culturing the specimen not only confirms the presence of group A streptococci but also allows for sensitivity testing, which becomes invaluable in cases of treatment failure or recurrent infections. While rapid antigen detection tests, RADs, are more commonly employed in diagnosing pharyngitis, they hold potential in quickly identifying streptococcal infections in pyoderma as well. Blood tests, though generally unnecessary, may be warranted in severe or systemic cases, where elevated inflammatory markers like CRP or ESR can provide additional insights. With diagnosis in hand, the journey of treatment begins, a journey guided by the principles of antimicrobial selection, the decision between topical and systemic therapy, and addressing any underlying conditions that may have paved the way for infection. Topical treatments are the frontline soldiers in managing mild impetigo and localized infections. Mupirocin ointment, 2%, applied 3 times daily for 5 to 10 days, stands as the first-line agent, prized for its efficacy against group A streptococcus. Retapamulin, 1%, another topical option, is applied twice daily for 5 days, offering an alternative for those who may have sensitivities to mupirocin. However, in cases where the infection is more widespread or when topical therapy alone is insufficient, systemic treatment becomes imperative. Oral antibiotics like penicillin VK, 250 mg 3 times daily, or amoxicillin, 500 mg 3 times daily, are the cornerstone of therapy for uncomplicated cases, administered over a 10-day course. For patients with mild penicillin allergies, alternatives like cephalexin or macrolides, such as erythromycin, clarithromycin, or azithromycin, offer effective options, each with their respective dosing regimens tailored to patient needs. In instances where the infection is severe, systemic involvement is evident, or oral therapy is impractical, intravenous antibiotics like penicillin G, cefazolin, or clindamycin are employed, ensuring that the battle against the infection is waged effectively from within the bloodstream. While antimicrobials are pivotal, comprehensive care extends beyond just fighting bacteria. Hygiene measures, keeping affected areas clean and dry, are essential in preventing the spread and recurrence of infection. In contagious forms like impetigo, isolation precautions become necessary to curb transmission within communities or households. Adjunctive measures such as continued use of topical agents, even when systemic therapy is initiated, ensure that the infection is eradicated from all fronts. Moreover, in cases of recurrent infections, exploring underlying causes like carrier states or immune deficiencies becomes crucial, paving the way for more targeted interventions. No journey is without its challenges, and Streptococcal pyoderma is no exception. If left unchecked, it can lead to serious complications, post-infectious glomerulonephritis, an immune-mediated condition where immune complexes deposit in the kidneys, leading to inflammation, rheumatic fever, a systemic inflammatory disease that can affect the joints, heart, and other organs, sepsis, a life-threatening response to infection, particularly in immunocompromised individuals or severe cases, chronic skin changes, including scarring or pigmentation alterations, which can have lasting cosmetic and psychological impacts. Prevention is our best defense against streptococcal pyoderma. Emphasizing hygiene practices, regular hand washing, maintaining clean skin, and proper wound care can significantly reduce the incidence of infection. Avoiding the sharing of personal items like towels and clothing minimizes the risk of transmission. In cases of recurrent infections, screening and decolonization strategies become paramount. Identifying carriers within household contacts and utilizing topical agents to eradicate the bacteria can break the cycle of recurrence, ensuring that both the patient and their close contacts remain protected. Allow me to paint a scenario that brings these concepts to life. Imagine a young child presenting with a honey-colored crust around their nose and mouth, a classic case of non-bullous impetigo. Through careful history-taking, you uncover that the child recently had varicella, and their living conditions are crowded with siblings attending daycare. A swab confirms the presence of Group A Streptococcus, and you initiate treatment with topical mupirocin, complemented by hygiene education for the family. Over the next week, the crusts fade, and the child returns with clear skin, free from complications. This case underscores the importance of prompt diagnosis, appropriate treatment, and preventive measures in managing Streptococcal Pyoderma effectively. In wrapping up our discussion, it's evident that Streptococcal Pyoderma, while common, demands our attention and expertise. Its manifestations range from mild impetigo to severe cellulitis, each requiring a tailored approach to diagnosis and management. By staying informed about its epidemiology, understanding the underlying pathogenesis, recognizing clinical signs, and adhering to evidence-based treatment protocols, we can ensure that our patients receive the highest standard of care. Let us remain vigilant, proactive, and compassionate in our approach, safeguarding our communities against the challenges posed by Streptococcal Pyoderma. Thank you for your attention. I now welcome any questions or discussions you may have on this topic.